Welcome to our presentation today on blood interpretation. I was hoping to cover a lot of it in this one webinar, but I thought it's quite difficult doing that because I wanted to cover, thoroughly in order to give you a good teaching. And, it's quite difficult to do in such a short amount of time. So I've split it over 2 webinars, actually, and we're going to deliver the latter in the new year. So this is part 1 of our blood interpretation webinar. And for those of you who have come before, welcome back. And for those that are new, we're going to do a short introduction into what our company is about. And like I say, thank you for joining us this evening. So what is Pareto Education? We're basically a team of physician associates, doctor, where our passion is teaching, and that's what we love to do. And we have a wide variety of offerings, whether that's in the online sphere, in face-to-face, in person, and we deliver all sorts of courses as well to a wide variety of multidisciplinary team professionals, widening our scope all the time. So thank you all for joining this evening, and hopefully you can get some benefit out of this and answer some questions as well. Okay, so a short video clip about us. So I think that clip just highlights a few of the things, a few of the spheres we're into, and what kind of things we're about. We launched this company been a little while now, and we're developing all the time our projects, our offerings for students, and also for qualified professionals as well. Okay, and where can you find us? You can find us on a wide variety of platforms, whether that's Facebook, YouTube, and also Instagram as well. On YouTube, we're uploading, some of our webinars as well. Some parts of this, after editing, will be uploaded onto YouTube. But it's always, good to come to these sessions live because you can get that interaction. You're more focused, more engaged, obviously, as a live session. You can find a lot of our stuff also on our website, where you can become a subscriber and get, get sort of emails, get the links on a first basis to everyone that's sort of subscribed to our subscriber list. And also we've launched a podcast quite recently. We've got a couple of episodes up. So if that's something you're interested in, the healthcare sphere, we're on YouTube. We've interviewed a few guests now as well, and also talking about our day-to-day lives, our NHS working lives on the front line, and our experience as well, which we're sharing. If you're interested in newsletter in a written format, you can do that also on. If you become a subscriber, you'll get a direct into your inbox, once every couple of weeks, a small newsletter with updates, some clinical information, interesting stories, new guidelines, that kind of thing, in interesting format. And those that are subscribed are definitely taking advantage of that. So yeah, just link up. A lot of this stuff is on our website, and if you do want to join with us, work with us, you're always welcome to do so. Okay, so in terms of this webinar, I thought I'd cover some key topics that come again and again, whether you're in working practice, in general practice, or in secondary care, or is something that examiners love to test, love to question on in exams. Oftentimes these questions come up not only in the the written multiple choice exams, but also the exam blood results are presented to you in sort of OSCE type scenarios, where you're interested to enable to work out what's going on with the patient, present a possible differential, and begin sort of thinking about management plans and that kind of thing. So I thought I'd cover some real foundational basics of some very, very commonly done blood tests that we find in the community and also in hospital. Like I say, obviously this is not the entirety of bloods. It's a whole specialist field in itself. It's very, very difficult to cover that in the entirety in a webinar, and that's why I have split it into 2. The next webinar that we hopefully will be running in January or February will cover a lot of the things like liver function tests, thyroid function tests, blood tests that we do in pregnancy, also other endocrinology blood tests, such as the ones we do diabetes and such, these kind of other blood tests, specialist blood tests, amylase, what's the significance of that, we'll be covering in our part 2. So make sure you do join up when we release the links for that webinar. But for today, this is a sort of a headline of what we'll be covering on our lecture for today. Okay, so bloods in itself is quite it's quite an important and quite a vital tool in your arsenal as a clinician, as a doctor, as a physician associate, as a allied health professional, and it's one of the things that enables you to look at a patient and investigate them fully to understand what's going on, what the possible reason for their presenting complaints are, for their symptoms, and begin that process of formulating a management plan. Blood tests are obviously not the first thing that you do, and it's variable in terms of how long certain blood tests take to come back. So, for example, in hepatology where I work, there's certain autoimmune blood tests that we send off that sometimes take weeks to come back. Some endocrinology tests that take long time to come back. But there are some blood tests that you can do at bedside. For example, blood glucose. Now that's a blood test that's done at bedside, and the result is pretty much instantaneous. There are other blood tests such as VBGs and ABGs, a venous blood gas and arterial blood gas, that can be run within 5 or 10 minutes, just waiting for the processor, to work, and it can be available to you within 10 minutes from you taking that sample to you getting the full results. And a lot of that information will be available. But if you're talking about, sending it to the laboratory, getting that full blood test, then it can depend also in what setting you are. For example, if you're in general practice, you don't really have that luxury of results back within a couple of hours. Unfortunately, it's a case of waiting a day or two to get their results back, particularly if they're acutely unwell, or in fact it might even take a week or so. So depending on which setting you're based in, will enable you to understand what how quickly you get these blood tests. So I've written a quick tool flow chart here in terms of how quickly certain diagnostic tools are available to you. And as a clinician, you do have a wide variety of tools available. That starts from your history taking. You're asking the patient. The patient will give you a lot of the information. Use the patient as a guide for your interpretation of what they're going to present with, what your thinking is going down the field, what you're going to treat them for. And the patient, a lot of the time, will tell you the diagnosis in the way they're presenting their symptoms. Yes, I have shortness of breath. Yes, I have night sweats. Yes, I've been coughing up blood. They will be telling you their warning signs, and it's up to you as a blood clinician to get that information listed from the patient as well. The next thing you can use is physical exam. You can see the patient. Are they looking breathless? In blood test, we're talking about anemia later. Are they looking, pale? Are they looking flushed? Have they got conjunctival pallor? What is the, at the bedside? Any signs you can elicit? Observations, obviously, blood pressure, etc. You can do that. Bloods now, this is the main crux of the lecture today. But also imaging, you've got after that with the CT, X-ray, ultrasound. And then after that, you've got specialist input. They will help you form a diagnosis potentially. Surgery is sometimes used for diagnostic purposes, whether that's not surgery as such, but colonoscopies, OGDs, or exploration surgeries, under anesthesia, which stands for EUA. And then finally, an MTD discussion, which is potentially for more complex patients. Okay, so that's sort of a formulation of what kind of things you have at your disposal as a clinician to help you form a diagnosis and then go forward, make a management plan for a patient. And as you can see, bloods is right up there because it's very, very important, and it'll help you make your decision about which patient is more sick. What's their chances of going into certain types of, for example, kidney failure, heart failure. For example, infection, how's the infection responding to antibiotics? All of this information, bloods will help guide you. I thought I'd put this slide up. It's not a hematology lecture as such, although this is a hematology picture in terms of, where blood cells are basically formed from. So as we all know, blood cells are formed, the red blood cells, the platelets, the white cells, the immune cells are mainly made in the bone marrow of the large bones, particularly in the bones of the leg. So, they start by a multipotent stem cell, and they differentiate into the two pathways. And as you can see, the erythrocytes, which is another name for red blood cells, are on the left here of the screen, and then thrombocytes, which is another name for platelets, are there as well on the left side. A lot of the immune cells you can see on the are disseminated between either pathways. Okay. So I thought I'd start with a quick glossary. So if anyone can sort of help me with this glossary, if anyone can understand, if anyone is aware of these terms, is understanding, has good insight, or perhaps would like a bit more clarification about what these terms are. Does anyone know what anemia is? If I could provide like a quick what is anemia? Can everyone still hear me?
It's a low hemoglobin.
Low HB.
Yes.
Yeah, low hemoglobin concentration. Yes. Okay, brilliant. So people can hear me. That's fine. Okay, good. Yeah, so low hemoglobin. So that's the red blood cells, and it's low amounts. We'll talk about exactly what low is, and how that is affecting different patients, and what the exact cutoff criteria in a little while. But let's leave it at that. Okay, what about thrombocytopenia? What is that?
Low platelets.
Yeah, low platelets, exactly. We're saying that. Very good. So that's low platelets. So we have another sort of, mean threshold where, a standard deviation where, platelets are expected to be in a certain range. And if they're beyond, or if they're beyond in terms of being too low, then that's considered a thrombocytopenia. Anyone know what pancytopenia is?
All three cells got affected.
Yeah, all three cells in terms of which ones?
Low count.
Yeah, low platelets, low red blood cells, and low white cells, correct. Yeah, very good. Everyone in the chat, Angela, yeah. Yeah, TH, yeah, very good. AKI, does anyone know what AKI is? Acute kidney injury, yeah, very good. CKD?
Chronic kidney disease.
Chronic kidney disease, yeah, very good. Okay, and hypokalemia, hyperkalemia is low and high potassium, and hyponatremia and hypernatremia is low and high sodium. Okay, very good, Emma, yeah, good. Okay, so let's talk about the range first of all. So this is the commonly accepted range, that it can be slightly up and down depending on which textbook you're looking at. But broadly speaking, this is the range that you'd be considering for a patient's blood test, okay? Especially for the full blood count. Now, hemoglobin, which is right at the top, which is the red blood cells we were talking about earlier. So the range is different for men and women. Men carry a slightly higher red blood cell amount than compared to women, in comparison to women. And that's just based on, the size of men and that kind of thing. So, that's just one differentiation that you should have between men and women, okay? Where can pediatric ranges be found? Okay, so pediatric ranges can be a bit difficult, can be based on age and then based on weight as well, because once patients are out of that small, neonate and baby range, then can be based more on weight rather than just age as well. It can be, I think it can be found on NICE give a lot of guidance on anemia, but anemia in children is a bit more worrying and should be investigated further. But I'm sure NICE would provide you with those guidelines, or as the pediatric society in Britain would provide those guidelines as well. That's your question, Susan. So mean cell volume is not an actual blood component. Mean cell volume actually just gives you the description of how big or small the red blood cells are. So we're expecting red blood cells to be between 80 and 100. That's the size of the blood cell. So that would be a normalcytic, normal sized red blood cell. Okay. Platelet wise, we're looking for platelets in between 150 and 400 times 10 to the 9 per liter in blood. Okay, so 150 to 400, that's the normal range. Anything below that, like we were saying before, can be considered a thrombocytopenia, and we'll talk more about that in later slides. Okay, white blood cells between 4 and 11, and neutrophils and lymphocytes considered, white cells as well, can be considered between 2 and 7 and 1 and 3. Okay, so there's sort of normal ranges. In terms of yourself, your own learning, the main things that you should be memorizing or committing to memory are the hemoglobin values, the mean cell values of the platelets. Anything more than that, in most bloods, they will give you the range, but I think they should expect you to sort of be familiar with those 3 components anyway: the hemoglobin, the mean cell volume, and the platelets. Don't worry too much, as you practice, as you gain clinical exposure, you will start to see it more and more, and you become familiar with these values as well. But it's always a good idea to commit these to memory. Okay, so anemia. So we said earlier that anemia is a low hemoglobin, so low HB, and it's due to low blood cells traveling around the body. So as you can see the range in the top corner, so for men, if anything below 130 could be considered possibly an anemia, and for women, anything less than 115. There is a special case as well in pregnancy. The plasma volume increases, which can give a low HB reading, although the amount of red blood cells remain the same. It's just the plasma volume has increased. This could be when you give any patient any IV fluids, either through resus or anything like that, you're increasing the amount of plasma volume, and obviously that will dilute the red blood cells. So that can give also a falsely low hemoglobin, indicating anemia when actually there isn't any. Okay. So when you are considering an anemia, you want to think about, is there a reduced production or is there increased loss? What's the reason for this anemia? Where is the problem arising? Is there less being produced or more being destroyed? So we already mentioned that the red blood cells are produced in the bone marrow, okay? And increased loss, so they're basically destroyed after red blood cells normally last around 90 days. And after that, they're destroyed by hemolysis, okay? So you want to be considering where extra losses are happening. Are they being destroyed too fast? Are they not structurally the same function? Are there being losses anywhere? So this is something that you must consider in patients presenting with an anemia. Oh yes, 120 days, my mistake, Priscilla, exactly right. 120 days, yeah. Between 90 and 120 days, yeah, you're right. Okay, so symptoms of anemia, what kind of symptoms would a patient present with if you're thinking that, a patient would present with something and you'd be suspecting an anemia as a potential diagnosis? Fatigue, shortness of breath, pallor, yeah, pale, pallor, yeah. Tiredness, tired all the time. Feeling cold, absolutely. Yeah, what was that, sorry?
Heart palpitation?
Potentially, yeah. Hair loss, yes, potentially, yeah. Feeling cold, tiredness, Patel, yeah, TH, shortness of breath, dizziness, that's a very, very good one, Isla. So yeah, these are the kind of things that you'd consider for someone that's presenting with anemia, potentially headaches as well. Another one is fainting. So, patients actually do faint. We had a recent patient that presented with a faint, and once they hit the head and they had a nosebleed and they came into the ENT outpatient. The doctors there were a bit confused about why they'd faint, so they did some routine blood tests and they found the patient very anemic with a HB of 43. Now he unfortunately had a peptic ulcer, and that was the reason for his bleed. Now that was not discovered until this faint, which led to the nosebleed, which led to being admitted, and then once the workup was done, that was found out the reason. So it can be becoming a wide variety of symptoms based on the low hemoglobin. Okay, so angular stomatitis, atrophic glossary. Yeah, these are the can be symptoms as well, although less common. And these can be commonly with iron deficiency anemia as well. Okay, so how would we differentiate the types of anemia? Now, we've mentioned earlier the mean cell volume. Now, this is something we look towards to give us an answer. There's also another type of blood test we can do as well that would help us potentially differentiate between types of anemia. And know what other types of blood tests we would potentially do? We'd look at MCV, yeah, Hafsa, yeah, Emma, yeah.
Ferritin, folate, and B12.
Yeah, exactly. Who said that? Very good.
Catherine.
Catherine, yeah, very good. So you'd check the hematinics. So you want to check, iron, ferritin, B12, folate. That's one of the first line investigations you would do, because these are some of the most common types of anemia, and you want to rule these out before you're thinking about other causes as well. Someone spot TFTs, iron studies. Yeah, that's also a good idea. Yeah. So these are the kind of things that you'd want to be thinking about when you're diagnosing a patient with anemia. You want to investigate really the reason why this patient is anemic, because there's not just one cause, there's a lot of causes of anemia. Okay. So the first we mentioned earlier, mean cell volume, people have been putting that in. So we're looking at microcytic anemia. Now, this is the case when there is anemia present. So for women, it's less than 115, for men, less than 130. But the mean cell volume, when you've done that red full blood count, the mean cell volume is less than 80. So, 60, 50, you commonly see. And this would give you an indication towards the potential cause. So out of these three causes, the most commonest cause of anemia in the world pretty much is iron deficiency anemia. Okay, apart from acute blood loss, that was pretty common, but apart from that is iron deficiency anemia, and that's one of the most commonest causes of iron deficient of anemia in the world. This is something that's diagnosed in 15 to 20% of menstruating women as well. So that's something that you'd want to be looking towards, especially in that category, but other categories as well, especially if you're considering they might potentially have a digestive disorder, which means that they're not absorbing iron properly. Thalassemia, this is another one, alpha or beta thalassemia. Now, this is a genetic disorder. You can have thalassemia trait, or you can have full thalassemia. This is a genetic trait where your red blood cells don't really carry the oxygen properly, and the red blood cells are not formed in the correct manner, which gives you potentially a problem with anemia. Now, this is a genetic disorder, and that's confirmed fully by DNA analysis. And the last one is a sideroblastic anemia, which is quite a rare condition. You wouldn't really be looking at that as a first sort of port of call with a microcytic anemia. If you're looking at microcytic anemia, the likely cause of that would be an iron deficiency cause. Okay. So like I say, we'll discuss the first one, which is iron deficiency anemia. Can anyone tell me what that in the top corner is, what that diagram is showing? That picture is showing.
It's Polonychia.
Polonychia, exactly. It's called spooning of the nails. Now you can see it's quite marked there. You're quite unlikely to see this now, because this is a complication of a long-standing iron deficiency anemia. And nowadays, especially in the UK, can be quite good at picking these up before it gets to the stage where patients would actually present with this polonychia. But from time to time, it does still happen. So, the most common reasons for iron deficiency anemia is like, more than heavy blood loss. Menorrhagia, like I was mentioning before, in menstruating women, that's going to be 14 to 20% of cases. Poor diet, a lot of cereals you might see nowadays are fortified with iron. This can top up your stores as well, but particularly if you have a very restrictive diet, that can cause iron deficiency anemia as well. And also malabsorption. So, if potentially you're looking at celiac disease, these patients could particularly potentially become iron deficiency anemic. Okay, like I say, sometimes it can present with, can be silent, it might not present with anything, but it can present with the earlier symptoms that we mentioned: shortness of breath, dizziness, headache, and these cholinicia, trophaglossitis, and the angular callosis as well, where the corners of the mouth are quite red, and so with the iron deficiency anemia. It's confirmed also with a low ferritin, less than 30 micrograms a liter, and we can also use a blood film in some patients. You'd want to take a celiac serology, especially if it's a non-menstruating woman. It would be quite strange, quite unusual for a non-menstruating woman to get iron deficiency anemia, although that's a common top. So you'd be thinking of celiac disease, and also possibly raging and of bleeding, and also colonoscopy for patients as well. For iron deficiency anemia, you'd want to treat the cause. So you want to treat what's the reason behind it. If it's if they have, you'd want, the amount and deficiency. Second, Olivia. So with menorrhagia, you want to, potentially then need some medication to sort of, lessen their blood flow. But most of these patients do require supplementation with iron tablets. That's oral ferrous sulfate. There are some other types as well, but that's the most commonest one given. These pills can sometimes, they have to take them quite regularly. And, oftentimes these patients are quite young. So, if you started a patient on oral ferrous sulfate, you'd want to check how, the blood tests in a couple of months and see how they're responding. And like Mariam has kindly put in the chat, a lot of these patients, unfortunately, because it is a longer course, and they generally start feeling a little bit better, they might not fully adhere to the course. So, if they're not responding, then you're wondering, why that is. Is it that they're not responding, or is it that they've not actually taken the medication? So you need to rule those two things out. And in that case, if it's not working, these patients might be headed towards IV iron, which means through the drip they might need iron. So there's common brands such as Ferinject, Monifer. Some of our IBD patients also unfortunately have developed iron deficiency anemia as well. So like I say, this is a very, very common cause of anemia, and it's something that you should be considering if a patient presents with microcytic, so small blood cells anemia. Okay. So normocytic anemia. Anyone got any ideas what kind of conditions can cause normocytic anemia? Acute blood loss, very good. Mariam, yeah. Anyone else? Chronic disease, yep. Chronic conditions, aplastic, yeah. So put it here. So these are the real reasons for a normocytic anemia. As you can see, in these situations, you'd present with a patient that was anemic, but also had a mean cell volume between 80 and 100. So this would be considered a normocytic anemia. One of the most common ones is acute blood loss. So, for example, a patient comes in, trauma. Once you take their blood, you'll see that, obviously, of course, they'll be anemic, but the mean cell volume of the cells they have would be normocytic. Okay, anemia of chronic disease, liver disease, renal disease, that kind of thing can cause a normocytic anemia. Although in some cases it can cause a low microcytic anemia. Bone marrow failure, renal disease is very, very common one. CKD is very, very common for a normocytic anemia. And we do unfortunately have to treat these patients with something called erythropoietin, which is a hormone that enables them, that the kidneys normally make, but don't really make in renal failure, that supports their red blood cell synthesis. Hypothyroidism, hemolysis, which is destroying of blood cells before maturity, and also pregnancy as well. So that these cases can also cause normocytic anemias. Normocytic, like I say, is anemia which is between 80 and 100 in size. Anemia of chronic disease. Do you think this is a rare anemia or a common anemia? You'd think you'd see this commonly in hospitals or common? Mariam's common. Anyone disagree? Del, do you disagree or do you agree? Common, yeah, okay, you agree. Very good. So yeah, it's actually a very, very common type of anemia. It's very, very commonly seen in hospitals, unfortunately. And there's three real reasons behind it. Either the body's, poor use of iron within the body to, make the red blood cells, shorten red blood cell survival, or there's some problem with the either production or use of erythropoietin in the body. So what kind of diseases can cause anemia of chronic disease? I don't know. Obviously, it'd be a chronic disease. It wouldn't be anything acute. But anyone know any examples? Liver, yes. Liver disease, correct. IBD, yeah, I'd consider that, yeah. Celiac, chronic renal failure, yeah. So these are some of them anyway that would potentially cause a anemia of chronic disease. So with these as well, you'd want to do some more blood tests if you're considering anemia of chronic disease. You'd want to do a blood film, B12, folate, thyroid stimulating hormone, someone mentioned earlier. You'd want to rule all these other things out before you'd sort of put it down to anemia of chronic disease. And oftentimes these patients are, because it's been going on for so long, they're quite well compensated. So they will not mention any of the side effect, the symptoms we mentioned earlier. They won't complain of, shortness of breath, headaches. They won't complaining of feeling faint or lack of energy. Their body has become adjusted to it. So that's another common thing to just to be aware of. Treat the underlying cause. So just try and get on top of the reason, if there's anything that the reason behind their chronic disease. So, whatever we can get on top of, we should get on top of in terms of the reason for the anemia, what the chronic disease is. They might need erythropoietin, which is, like I say, a hormone for stimulating red blood cell production produced by the kidneys. And also they might need IV iron as well. Sometimes these patients just need supplementation of that. Oftentimes these patients are not really that suitable for red blood cell transfusions, but we'll talk about that in a second, about which patients are suitable and which are not. Okay. So that is the second most commonest type of anemia, especially in hospitals. Unfortunately, a lot of patients do have this on top of their other chronic disease as well. So we've got macrocytic anemia, and that's stipulated by high mean cell volume of the red blood cells. So you see these patients, they are anemic, but the actual size of the cell is larger than normal. So there's a couple of things here. Basically, macrocytic anemia is split into two subcategories, the megaloblastic and the non-megaloblastic. And those are, as you can see in the table, would be the B12 and the folate deficiencies, alcohol excess, and liver disease. Cytotoxics, which are mainly the chemo drugs, would be under that category. And then on the other side, with the non-megaloblastic, you've got these syndromes, any infiltration, hypothyroidism again, antifolate drugs, especially phenytoin, and reticulocytosis. And so that's a real reason between the splitting. So the exam question might ask you, so the patient is presenting with this, what kind of anemia is it? And then they will ask you, okay, so you'd know it was a macrocytic anemia, but then it'd be further split, is it a megaloblastic or non-megaloblastic? And that just describes the shape of it, really. Folate deficiency. Which vitamin is folate? Does anyone know? Does anyone know that? B9, yes. Also known as B9, as used for DNA synthesis and other functions. So it's involved in the synthesis of also red blood cells in that progenesis as well. And it's found in our diet mainly. So, although we can have some body stores, we would gain this mainly from our diet. So it's found in green veg, nuts, and also fortified foods, which in these days particularly tends to be cereals. So if you eat a lot of cereals, you're getting a lot of your. But a lot of people do take supplementation for this. It's synthesized in the gut bacteria and it's absorbed by the small bowel. So obviously, if there's any issues with that, we can cause a folate deficiency. Like I say, it can be reason behind a poor diet, increased demand, whether that's in a pregnant state, if you've got cancer, inflammatory disease, hemodialysis. You're acquiring, you're using up a lot more of your folate. Malabsorption, again, we're looking at celiac disease, alcoholics, unfortunately, and sort of certain medication. Folate deficiency, you'd want to so once you do your blood test, you found anemia, you found this macrocytic anemia, and then you've done a hematinics and you found it's a folate deficiency. You don't want to potentially, if there's no underlying cause, then you would potentially give them, folic acid as a supplement. But in this case, you would ensure that B12 is normal, because oftentimes these patients have both B12 and folate deficiency. It often comes in combination. So B12 deficiency, so that's another B vitamin that we get in our diet. Now, what kind of foods would we be looking at for B12? So if I was saying a patient needs to increase, what kind of foods would help them with their B12 deficiency? Citrus. Probably not the best reason. Meat. So people are putting meat. Yeah, meat, eggs, yeah. Steak, yeah, sure, yeah. This meeting won't be finished, don't worry. It'll continue, don't worry. If there's any problems, do let me know. I'm just hoping no one's starts logging off. We've got a little bit to go yet. So yeah, eggs, yeah, brilliant. So it's very important in DNA synthesis, and if low, red blood cells production is low in the bone marrow. 15% of older patients unfortunately have B12 deficiency. A lot of the cause is dietary, so people are vegans, vegetarians, and B12 is in majority animal products. So you find in eggs, steaks, that kind of thing. So red meat. So you'd want to be thinking about that. And malabsorption can also be due to something called intrinsic factor, which is used in the absorption of this B12 in the terminal ileum of the intestine. Symptoms can be, again, of anemia. Patients can often present with a mild jaundice. Might not be visible to you. And also in late stages, they can present actually with neurological symptoms. So this is something that you'd want to catch quite early, okay? And then pernicious anemia is autoimmune disease in which the atrophic gastritis, which is basically that type of gas, leads to low intrinsic factor being produced from the parietal cells in the stomach. So there's low intrinsic factor being produced, which means that even if you're eating enough B12, it remains unbound. So it's really being up to the into the body at the terminal ileum of the intestine, so it's not absorbed and it's just lost. So patients can become anemic in this way. So in this case, you'd give them B12, initially IM, and then depending on the result of that, oral B12 can be given later. Also, obviously, you'd present this patient with dietary advice, and perhaps they would like to consider, more certain types of red meat products, eggs, milk into their diet as well. Okay, so that really, I mean, obviously there's loads of different conditions that can cause different types of anemia, and it would be a very long lecture if I covered every single type, but these are the main types of anemia that they would like to ask you about. So they will ask you about B12 deficiency, they'll ask you about iron deficiency anemia, they'll ask you about folate. These are the types of, and at PA level, this level, this is the sort of initial baseline knowledge that you would be expected to know going into sort of exams. There are a lot of causes of anemia. Acute blood loss, that's another cause, that can be present quite obviously, or it can be insidious. You can have blood loss insidiously, so which means silently. That's the most commonest tract is into the GI tract. So, patients can have an ulcer, a peptic ulcer commonly, or a duodenal ulcer, and they can be bleeding from that. People often think that, if this is happening, they will always present with, black stools, melena, or they will always present with hematemesis or coffee ground vomit, but that's not always the case. You can have this low-lying, low-grade bleed and you're not being aware of that. And that's something that you should be aware of. The patient I was telling you about earlier who presented to the ENT department after a fall, he had actually a peptic ulcer, and that was found on OGD, but he didn't really explain any symptoms of vomiting blood or losing blood in the stool. So this is something that you should be aware of. So oftentimes in anemias, the question you will be presented with in your clinical practice is, do I transfuse this patient or do I not transfuse this patient? And that's can be quite a tough question to answer, really. Obviously, if the patient, has got a very low hemoglobin, maybe if 40 or something like that, you'd obviously transfuse this patient. But what in some other cases? What if HB is above 70? Would you transfuse this patient?
I don't think so. We'll try to manage with the medications, depending on the circumstances.
Yeah, if they are unstable, yes, because if symptomatic, potentially. But in most cases of HB of 70 and it's not dropping, or the patient's clinic is stable, they're not in shock, which means their blood pressure is holding, the heart rate is steady, they're not very symptomatic with it, unless cardiac patient potentially, then we'd try consider not transfusing them with iron. Someone said we'll try iron infusion first. Yeah, potentially, if that's a reason for their low blood, but potentially we would try and avoid a transfusion, because transfusions, not only do they use up the hospital supply, but it can be quite tricky. There's increased chance of reactions. People can become develop a reaction to this transfusion of red blood cells. So if we can help it, we try not to transfuse. So for patients above 70 and they're stable, or if they're chronic, we'd probably not transfuse this. We can get, if they found this iron deficiency anemia, we can give them iron supplementation, even IV iron, through the drip, and that's a lot safer and it's more cost effective to deliver in this manner. If the patient is acute anemia, so if something acutely has happened, or they have come in with the upper GI bleed or something like that, peptic ulcer, or the hemorrhaging, or it's a trauma call, anything like that, transfusion is indicated in these circumstances. Even sometimes, even if the HB is above 70, but definitely if the HB is below 70, in these sort of cases, we would sort of think about transfusing this patient sooner rather than later. Someone mentioned cardiac patient. Say a patient has a congestive heart failure, but they're presenting with anemia. They've got severe anemia. Anything we'd want to look out for, we'd want to do, we'd want to consider?
We'll try to avoid transfusion because it can cause congestive cardiac failure. There are
Yeah.
chances.
So it can cause like flash edema, can't it? You know, if patients got congestive heart failure, unfortunately, they've got heart failure. It can cause congestive. It can cause a flash edema. So we want to be very, very careful unless they very much need it. You know, the HB is very low or they're unstable. We would try and avoid it if possible. We'd possibly transfuse it more slower than we would the normal patient. And you might need, if, for example, if they're needing 2 bags or at the end of the bag, we might need to give them some diuretics, some IV furosemide or something like that, just to control the amount of fluid they're holding on their body, just to, you know, decrease the risk of a flash pulmonary edema, you know, causing that, you know, a lot of fluid in their chest. Okay. Does that make sense?
Yes.
Yeah. Okay. Thrombocytopenia. So we mentioned this earlier. Can someone just remind me what thrombocytopenia is?
Low platelets.
Low platelets, yeah, perfect. So low platelets, you know, we've got the range at the top. You know, at what level do we clinically become, you know, really concerned? You know, what level do we think that, you know, this is something that we need to keep an eye on, or, you know, potentially?
Is then 25, 30?
Yeah, that's so 25, 30, yeah, that's quite low. Definitely be worried about them. But, you know, the guidelines say that, you know, potentially less than 50, we want to be considering these patients. Anything less than, you know, between 50 and 150, you know, that's still within like a standard deviation of the main group. So, you know, these patients potentially could just be, you know, something that they normally are, you know, there's individual variation. But at less than 50, we want to be keep an eye on these patients, because at this level, they can become, you know, have symptoms. What are the main symptoms of a thrombocytopenia? What would a patient typically present with? So we said low platelets. Now platelets are involved in blood clotting. So what kind of symptoms would a patient present with if they
Increased bleeding.
increase bleeding? Yes, so they might have bleeding gums. That's a common one. They might nick themselves while shaving, and, you know, it's difficult for it to stop bleeding. They might have easy bruising. So, you know, you can see the patient at the top in that corner. You know, there's a lot of bruising there.
Nosebleeds.
Nosebleeds, Alicia, and whoever's on the chat as well. Yeah, very good. So nosebleeds is another one that's very common. You know, it takes a while for that to stop bleeding, and, you know, patients can become annoyed. You know, why is it not bleeding? Why is it not stop bleeding? You know, even though it's, and then once clinical investigations are done, it's found out their platelet levels are very low. And then you tell them that the reason behind this is because the blood cells that are involved with clotting are very low in this patient. So they become really clinically relevant at 50. Now, someone said earlier 25, 30. At that level, you're going to have a lot more symptoms. You're going to have, you know, a large amount of bruising, spontaneous bruising. You don't have to hit anything, or, you know, spontaneous perhaps bleeding from the gums or other areas as well. So at 25, 30 is a lot more significant than at 50, but it starts becoming relevant. You want to keep an eye on these patients at 50. So causes, what could the causes potentially be? Does anyone know any causes of thrombocytopenia? Would be impressive. Latest one is COVID vaccine, potentially, yeah. Yeah. Aplastic bone marrow, ITP, yeah. Genetics, yeah, very, very good. F. Put in. Induced thrombocytopenia, yeah. ITP, yeah. So we've got a few here as well. So inherited disorders, dehydration, leukemias, liver failure, sepsis. Patients can become thrombocytopenic. Medication related, and again, pregnancy can cause that. Alkyd liver disease, yeah, exactly, Susan, yeah. So these are some of the causes behind it, and you can see the picture on the left. You've got pura and also petechiae as well. Does anyone know which one's which? Which one is the petechiae and which is pura?
Top one is a purpura and the low bottom one is a petechiae.
Yeah, that's right. Exactly right. Yeah. So the bottom is petechia. Yeah. So you want to be considering these. Sometimes patients come in, maybe if even children, you'd be considering, if they come in like this, one of your differentials possibly would be a leukemia as well, wouldn't it? So this is something that you want to be aware of, particularly with patients like this. Like I say, these are the sort of symptoms that patient would present with. Silent, particularly, around 50, 40, maybe you'd be silent, but then, they would, as the platelets would depleted, they would get more and more bruising and ED bleeding. Anyone know the treatment for this?
We give platelet infusion, depending on the label. We give platelet infusion, no? Depending on the symptoms and
Yeah.
complexity.
So yeah, so if the patient is symptomatic, we would give potentially platelets to this patient. Also, if they're going for some kind of surgery, that kind of thing, they'd potentially need platelets as well, especially because obviously there are increased risk of bleeding. And sometimes patients can also be treated with steroids. Mariam, I'll get back to you in terms of which kind of medications cause thrombocytopenia. There are some I was researching earlier, I didn't remember, it just slipped my mind, so I'll come back to you with that one. Okay. Normally below 50, we would transfuse. Okay. Happy? So we'll talk a little bit about kidney function as well. I'm considering the time as well. I don't want to take too much of your time this evening. So these are the sort of normal ranges that you'd consider for a kidney function test. Sodium, you've got potassium, urea, creatinine, and EGFR. Although it says over 60, some places say over 90, just depends on the age of the patient. And, EGFR is actually an estimated glomerular filtration rate. And, sometimes it's used more commonly just because it's a little more sensitive than creatinine for indicating the degree of renal impairment. Okay. So the first test is urea. Now this is an organic compound and it's formed when there's breakdown of proteins and amino acids, and it's cleared by the kidneys via urine. So this is so if the kidneys are not working very well, obviously urea will build up in the bloodstream. So this is a very, very good indicator that there's something going on with the kidneys. The kidneys are not happy, they're not working well, they're not working efficiently. Because it's excreted by the kidneys, we can then assess the serum urea to assess how efficiently the kidneys are working. Now, there's a bit of variation between urea and creatinine. So if there's increased urea and normal creatinine, potentially that would indicate a pre-renal cause, and it might be due to a high protein diet, increased protein metabolism, and this is very common in patients who, for example, bodybuilders, they'd be taking a high protein diet, someone who just finished like a marathon, something like that. Also, this is a case, increased urea and normal creatinine after a GI hemorrhage. So as the blood proteins, if you're bleeding in your GI tract, your blood proteins, as they go through particularly the small intestine, they are broken down, and this translates to a higher urea. And this would cause an increased, a mismatched increase of urea compared to the creatinine. Okay, steroid treatment can also cause it, and dehydration or decreased perfusion of the kidneys. So like I say, pre-renal cause. An increase in both urea and creatinine might indicate an obstructive post-renal condition, such as malignancy, kidney stones, or anything to do with the prostate. A low urea and an increased creatinine may indicate an acute tubular necrosis within the kidneys. A low protein indicate intake, starvation, or severe liver disease. Now, this is a sort of variation between what urea shows and what creatinine would indicate. Creatinine, on the other hand, is a chemical component left over after energy is produced in the muscles. So after all the Krebs cycle and the ATP is synthesized, creatinine is one of the waste products. And healthy kidneys also filter out creatinine through the urine. Increased amounts would indicate a dehydration. Like I was saying, some people go to the gym, etc., do supplement with creatine, and that can sometimes cause a falsely high creatinine. High muscle mass can also cause a falsely high creatinine, and also the inverse is also true. Certain patients who have sarcopenia, which is the medical term for low muscle mass, can also give a falsely low creatinine in comparison to what their kidneys are actually functioning like. An AKI would cause a high creatinine as well as poor kidney function in CKD patients, chronic kidney disease patients. In these kind of patients, you want to treat the cause, whether that's pre-renal, renal, or post-renal. Whatever the cause is, you'd want to treat the cause leading to the high creatinine in these patients. And you can see the general sort of trend, the general range in the top corner. I thought I'd touch briefly on acute kidney injury based on these slides. It's something that's very, very important and very, very commonly seen as well. So it's basically a rise in creatinine over the baseline. So you've got a couple of definitions of what an acute kidney injury can constitute of. So it's a rise in creatinine over 26 within 24 hours. It's a rise in creatinine over 1.5 of the baseline, or it's a decrease in the urine output urine output of less than 0.5 mil per kilogram per hour in over 6 hours. So these all sort of constitute the overall definition of an acute kidney injury. As you can see, urea is not mentioned here, so it's creatinine that they use. Okay. There's reasons behind acute kidney injuries, and I've listed some of the most common ones here. So we're talking about pre-renal causes, where hemorrhages, DNV, which is diarrhea and vomiting. That's a common cause of pre-renal AKI. Shock, so if a patient is shocked, and also septic, and certain medications can cause AKIs as well, such as things like metformin can cause AKI, ACE inhibitors, that kind of thing. NSAIDs. Renal cause, glomerulonephritis, acute tubular nephrosis, drug reactions, infections, and vasculitis, and post-renal, kidney stones, malignancies, strictures, clots, anything to do with the prostate as well. Like I say, examine these patients and make sure you catheterize them and get good fluid balance with, regular monitoring of their kidney function via blood tests. And you'd sort of treat them as listed below. So you want to treat the cause, stop any causative agents, whether that's nephrotoxic medication or diuretics, which can also push the kidney to work more harder. So you'd want to perhaps consider those in patients that have got acute kidney injury. And give them gastroprotection and nutritional support as well. Potentially, these patients need fluid resus with hydration. Okay. So this is an example of a patient. Can you tell me anything about this patient? What you'd be considering? What the range values are? I've helpfully given you the ranges, so it should be kind of straightforward. What kind of things are you considering for this patient? What things are you worried about?
It's an AKI.
Okay, potentially it's an AKI. What would help you to tell you if it's an AKI or a CKD? What do you need? What information do you need?
Is the EGFR from that?
EGFR is 15, but baseline, exactly, Serena, brilliant in the chat. Yeah, so you basically want the patient's baseline. So what the previous results are, Rachel, again, yeah, good. So in the last couple of days, what's the normal trend? Have they been to, are they known to nephrology team? Have they got a diagnosis of CKD? What's their baseline? What do they normally sit at? If the patient normally has a creatinine of 100 and all of a sudden it's 383, then you're definitely thinking an AKI. But potentially this patient could have a CKD as well. We've got a couple of things here, going on with this patient. We've got the, very high urea, very, very high actually, 32.6. Creatinine is also raised at 380. EGFR is low. Someone put potassium, Patel, yeah. So potassium is high, 5.3, mildly high, but some places do consider up to 5.3 as normal, but in this range, you would consider that mildly high. And sodium is also a little bit high. Potentially, what's the most likely? If I say this is not what the normal patient is like, if this looks like an AKI picture, isn't it? And the degree of which the urea has elevated also gives you an indication that potentially this is a dehydration picture, because like I said, the urea is very, very high. The creatinine is also high. Potentially also it could be a GI bleed as well, because look, the urea is more higher than the creatinine in comparison, isn't it? It's elevated much, much higher in comparison to the creatinine. So you'd want to consider this. Michelle, yeah, you'd want to get a fluid balance chart. You'd want to, consider the mucous membranes. How much is the patient taking on? How much are they excreting fluids? And you'd want to be making sure that this patient you've got on top, because this looks like potentially a very sick patient that could go the wrong way. Okay. So that's like just an example of something that you consider something very, very common. Potentially you'd see that in A&E or, on the wards, and even in GP practice, you'd consider this patient and, potentially this patient needs admission. Could this be an acute on chronic kidney disease? Yes. So if the baseline is, for example, creatinine 250, the creatinine has still increased, hasn't it? It's gone up 1.5 the baseline. So you'd still consider this an AKI, yeah? As part of the KDIGO definition. So very good, Patel. Yeah, very good. So a brief overview of chronic kidney disease. So this is basically a deranged function of the kidneys was a matter over 3 months, and is classified by the glomerular filtration rate. The most commonest reasons behind it are, unfortunately, diabetes. So as diabetes increases in this country, so does chronic kidney disease. Glomerulonephritis and vascular issues also constitute a large amount. Short symptoms are listed as on the slide. The patients potentially have, shortness of breath, nausea, vomiting, or they might even have no symptoms at all. That's also possible. They can have a raised JVP, a lot of fluid on them, edema, and also vasculitic rash. So you'd want to get some good bloods of this patient, get a good battery of tests going, including of, autoimmune bloods such as the ANA anchor, intrinsic renal bloods. Ultrasound scan potentially you'd want to do of the kidneys to see if they're atrophic, meaning are they small? Are they, is there any hydronephrosis there? Are they waterlogged? Is there any cause behind this, potentially as chronic kidney disease? For this, you'd want to sort of monitor the patient and keep on top of a few other things. So, we know that, blood pressure is related to poor kidney function. So keep their blood pressure under control. Also their blood glucose as well. Advise them on lifestyle. I don't want to turn this into a nephrology lecture. Obviously, it's on bloods, but I thought I'd put this in just in case someone was just wanting a bit of a recap on chronic kidney disease from this. So we mentioned earlier, patients can go from, have an acute kidney injury on top of their chronic kidney disease. So it's very, very important to get their baseline kidney function results, and that's one of the benefits of an electronic computer systems, which logs all blood, so we can get them quite easily. And patients are potentially get worse and worse over time, and then you'd potentially want to consider them for things like dialysis, unfortunately, in the late stages. Because unfortunately the kidneys become pretty much inefficient, not working at all. They don't produce any urine. So obviously we still need to get rid of all the waste products, the urea, the creatinine, the sodium, the potassium, and keep them in within healthy normal ranges for homeostasis. Okay. So potassium, this is another salt that's very, very important. You find this in your kidney function tests, and this is the salt that's used to keep certain vascular pressures and concentrations. It aids in muscle and myocardial contraction, nerve impulses, and fluid regulation. High and low potassium can be affected by diet, beans, nuts, bananas, very, very commonly. Even patients know about that one, that bananas contain potassium. So that's something that you should be considering, when you're considering a patient with high potassium. But more commonly is things like medications, potassium-sparing diuretics, ACE inhibitors can affect their levels of potassium. Chronic kidney disease can also affect potassium levels, AKI, CKD. For patients on dialysis or not, maybe they've potentially missed a dialysis session and their potassium levels are building up because they've not had a chance to excrete it. And diarrhea and vomiting, if that's more of a common cause as well. Patients presenting with diarrhea and vomiting, they come to A&E and you'll find that their potassium and their sodiums are quite low. And the reason behind that is because they're vomiting a lot of their electrolytes up. So anything less than 3.5, you'd consider, that as a hypokalemia, a low potassium. Potentially these patients would present with muscle cramps, fatigue, and you'd want to replace that. Ideally with oral solutions first, or normally you get some oral supplements. So the most commonest one is colloquially known as Sandoke. It's just potassium supplements. It's you can mix it with a drink or a tablet, or in some cases then you do need to give certain patients IV potassium. You can see in the top corner 3.5 to 5. Now potassium we want to be keeping a close eye on. If potassium is high, are we worried, or is this okay, or what is that? Are you worried about a high potassium for a patient? Conversely.
Yes.
Yes, okay, very good. We are worried. Yep, we are worried. Cardiac arrest, yes, can affect heart. Arrhythmias, yeah. So high potassium is something that you want to be very, very careful with, because exactly right, it can cause arrhythmias, it can cause a cardiac arrest, it can kill a patient. So you want to be very, very careful in terms of hyperkalemia. So when you're considering your kidney function test, you get potassium on there, and if there is a potential high potassium, you want to make sure that this is this is a true. First of all, potassium can sometimes be falsely elevated on blood tests. This can be for a wide variety of reasons. If the potassium is left in the bottle for too long, for example, if it's in a GP practice and it's collected at the end of the day when it gets to the analyzer, or it's shaken too much, it's coagulated, or it's hemolyzed, or whatever's happened, that can cause problems and give you a falsely high potassium. Now, this don't just assume potassium is falsely high. You need to investigate this further with a repeat blood test, okay? To ensure that the potassium was correct or not. So if you are considering that potassium is definitely high, or it is a true high sample, then these are the sort of algorithms you need to follow to ensure that adverse effects are not abided by with this patient. So you want to prevent arrhythmias, you want to prevent all this. So you want to give fast treatment to this patient. So confirm your diagnosis with a VBG, and then in a large, if high, always confirm by retest. So I normally do confirm with the retest. So in the time that ECG is set up and everything, I would confirm, because ABG or a VBG takes a couple of minutes to run. I would sort of, while the ECG is getting set up by another of my colleagues, I would sort of get a VB just to understand exactly what the high potassium is, and if it is definitely high, that kind of thing. Unless you're very much considering that it was a spurious sample, that there was an error by the lab, or it was sat too long or anything, you would consider that it's a true sample and you would begin treatment pathways, okay? Because it is such a serious condition. The first thing you would do is, give them 10 ml of 10% calcium chloride, and that's for cardioprotection. And then you want to get rid of the potassium back into cells. So the way we do that is by giving IV insulin at 10 units. in some glucose. And then monitor for hypoglycemia, because obviously you've given them a big shot of insulin, especially if they're not diabetic. Salbutamol can also play a part, and that can help shift the potassium as well. Beware, patients will develop a tremor after this, especially if they're having back-to-back nebulized salbutamol. And if the potassium is still high, then at this point you'd potentially want to consider, further consult with the nephrology team, or making sure that the patient is, because like I say, it's very, very serious. This can kill patients, so we want to be on top of this. Okay, so hyperkalemia, look at the level, ACG, consider a VBG, and start treatment. Calcium chloride, insulin. Okay. And this is a typical ECG that's found with patients with hyperkalemia. As you can see, it's very, very obvious here. You've got the tall tented T waves, that's what they're considered. Broad, bizarre QRX complexes, and they're very, very large, and you'd be able to, while it gives salbutamol, sorry, it also helps drive potassium back into the cells. So from the blood circulation, it will drive it back into the actual cells surrounding the blood supply, so it decreases the risk of the potassium going to the heart. Okay, does that make sense? Hopefully it does. So I thought I'd touch quickly on D-dimer, this question of sensitivity versus specificity. Okay, now, does anyone know what D-dimer is, what it's used for? I suppose, anyone know when we'd VTE yet? What was that, sorry? Yeah, so Nia, yeah, Shazia, yeah, F, yeah, measure blood clot, yeah. So D-dimer is in fact itself a protein fragment. It's basically a fibrin degradation product. So after the fibrinolysis of blood clots, protein fragment is derived, and we're measuring for that protein fragment. It's actually 2 strands, so that's why it's called a D-dimer. And we want to be really looking for this level, and that would give us an indication that we'd consider a potential diagnosis of a clot for a certain patient. And the main clots really we're worried about, people have been putting in the chat as well, are DVTs, also known as deep vein thrombosis, and also pulmonary embolism as well. So these are the 2 main clots that we'd consider for these patients. What's the difference between sensitivity and specificity? Is this, if I've got a raised D-dimer, does that mean I've definitely got a clot? Nadia, you've put sometimes not very specific, I've been told. No. People have been putting no.
Infection can raise D-dimer, isn't it?
What can raise D-dimer?
Infection.
Infection, yes. Anything else? Pregnancy, Priscilla, yeah. Anything else?
Surgery.
Yeah, surgery, yeah.
Mobilization, so yeah. Or the
immobilization. Immobilization. Yeah, so certain things can cause a falsely elevated D-dimer. Mariam, you put age as well. So yeah, so we can do an age-adjusted D-dimer, and then you'd find this on MedCalc, and you put the age of the patient in and the reported D-dimer. So if you'd consider, in our trust, they consider a normal D-dimer of below 230. So anything above that, based on how high it is and what your clinical suspicion is, would be possibly a positive D-dimer. But like you say, there are a lot of things that can cause an elevated D-dimer result. And, like say, infection, cancer, pregnancy, these kind of things can cause a falsely elevated. So if I'm considering, for example, blood clot in the leg, and say the D-dimer is 350, not massively elevated, but I do have that little bit of suspicion. What's my next go-to investigation? Doppler, yeah, ultrasound, yeah. So you've done your well score, and then you're getting that the ultrasound scan. What about if I think it's a blood clot in the lungs, a pulmonary embolism? What's my, am I doing another ultrasound? CTPA, yeah. So CT pulmonary angiogram. So like I say, this test can be quite sensitive. You know, if it is elevated, there is something going on, but it might not be the reason. Oftentimes, pregnant ladies come in and, you know, they're complaining of some chest tightness, some shortness of breath. And, you know, pregnancy itself is a hypercoagulable state. So, you know, they're very much at risk of blood clots. Now, in these cases, D-dimers are not very useful at all because they're going to be elevated, and you have to think to yourself as a clinician, am I going to proceed with the, you know, more of, you know, investigations regardless of this D-dimer result? What am I going to do once I got this D-dimer result? You know, what's my next port of call? Okay, so that's something that you've got to consider. You know, just because you have a certain result on a blood test does not always mean that that's definitely the way you're going to proceed. You know, and even if sometimes you have a low a D-dimer, sometimes with your clinical suspicion, you would still proceed after, you know, discussion with your radiology imaging colleagues that, you know, I still want this test. So sensitivity is, you know, if a certain sensitivity just means that if a DVT or a PE is present, it will definitely pick it up. So D-dimer tests are very, very sensitive. That means that if there is a clot like that, it will pick it up. It's sensitive to that. Specificity means, is it only sensitive to that? The answer to that is no, because it's not specific. It will be increased in pregnancy. It'll be increased in malignancy. It'll be increased in infection. So the test is sensitive, but not specific. Hope that answers the question. Yeah, so a lot of patients, yeah, so pregnant patients, would you still opt for CTPA? Yeah, so a lot of the times we still do. There is, you know, textbooks say, you know, VQ scan and all of this sort of thing. But, you know, in most cases, we do counsel the patient, you know, and depending on the trimester and, you know, if, you know, the radiologist is happy, you know, we sometimes do CTPA scans depending on the progression of the pregnancy. In our trust, we do VQ scans. We do VQ scans sometimes, but, you know, I think CTPAs are more readily available. So I think sometimes at my trust we do that as well. Okay. It's just because CTPA, you're injecting dye, and it's quite a high amount of radiation as well. So they're just worried about the radiation to the baby, and also the dye as well that can affect the baby. So that's just the reason why we're considering a different scan compared to CTPA for those that are wondering. So last little bit now, troponin and its role in MI investigation. So it's similar to the what we are discussing just now, D-dimer. So troponin is similar to D-dimer. It's a protein that's, thank you, Petra, thank you, just slipped my mind, you know. Troponin is a protein involved in the best for nationals. Juliana, I would say just put VQ scan. We do sometimes do CT scans, but I would say put VQ scan because that is a highlight, the gold standard for pregnant ladies. Okay, hope that helps. So troponin is involved in cardiac and skeletal muscle contraction. It's a muscle that helps. And if myocardial cells are damaged, troponin is released. So if we've got a patient coming with chest pain, you know, as well as our other investigations, such as ECGs, we will go to get a troponin. And that will help us elicit the ACS treatment, okay? Acute coronary syndrome. Troponin I and T are more specific. So these are the most ones, and these are the measured with acute coronary syndrome. However, troponin can be high with other causes, like we were mentioning earlier. It's not specific to a STEMI or a non-STEMI. You know what I mean? You know, that's why we need to consider everything once we've got a troponin that's elevated. Now, say we have a troponin that's elevated. You know, say we've got a patient whose troponins come back as, for example, 20. What's our next step? You know, can we use that in you know, by itself? What's the next step? Say they don't have any. Yeah, so we've got ECG. Yeah. Would we use that test in solo? Repeat after 4 hours. Who's put that? Michelle, Emma, yeah. Repeat, Trop, Mariam, yeah. Very good. So you want to repeat this because the value is in repeating the test. A lot of these conditions, myocarditis, pericarditis, you know, tachyarrhythmias, they're not likely to change hour by hour. But if it's something that's genuinely ACS, there would be an increase in the troponin between the first initial troponin taken and the second one as well. So that's our main sort of differentiating factor, you know, helping us diagnose this patient with ACS. Okay. Like I say, ECG is obviously good, but we do start. But do we start treatment for ACS anyway? Yeah, so in that case, you know, if we're considering the patient has got chest pain, perhaps they've got ST elevation, or, you know, they've got troponin, we would start this anyway. And, you know, if we've got a strong consideration and there is troponin rise in the first blood test, but there is no ST elevation, we would still start the ACS treatment pathway anyway, including, you know, aspirin, everything like that, potentially consideration for cath lab, you know, even if they have like NSTEMI. So we would consider them with, you know, dual antiplatelets, you know, and keep an eye on their troponin to see what their repeat troponin is. You know, give them pain relief and see what their repeat troponin is. Obviously, we wouldn't send these patients to the cath lab if it's NSTEMI, but we would keep an eye on and definitely repeat the troponin and see what the values are. Okay. And like I said, there are other reasons for causes, an increased cause of troponin. So we've got PEs can also cause troponin rises. Something like subarachnoid hemorrhages can also cause burns, sepsis, renal failure. These can also cause rise in troponin. But like I say, the most important thing is the number, the rise in the number rather in the serial blood tests. So plus ECG, plus symptoms, you know, you need all of this. So that's often the case, the thing in blood tests. You should never use a blood test in, you know, solo. It should always be as part of your management plan, as part of your investigations, as part of your diagnosis.